I'm not really going to talk about the chemistry and psychiatry of tapering. Dr. Sullivan is, because he's the real expert in that topic. But what I'm going to follow up on what I was talking about this morning, and that is, I'm going to set him up for why it's so difficult in reality to taper people. And it's because of the neuroadaptations that occur when people are on opiates continuously and for a very long time. So let's start by considering the role of the endogenous opioid system, which I was really focused on this morning. So that's, in terms of pain, this whole concept of the top-down viewpoint of how we envisage pain now, and the very important role of the opioid or endogenous opioid system in that process. And that is that this system provides stress-related pain relief and enhancement of pain in response to stress. And this system also facilitates maternal, infant, and other attachments, so social aspects of pain are very much mediated by this system. And the other important thing is that this endogenous system, particularly the mesocorticolimbic system, or the so-called reward center, is designed to perpetuate favorable behaviors. And it's because of the existence of that system that when you give an exogenous opioid, it's going to sort of commandeer that system and do the same thing. So in the absence of those favorable behaviors, it's going to produce the reward. So that's another aspect of why it is that what we're seeing is adaptations when exogenous drugs are given that are all based on what the endogenous system does. So the neuroadaptations are integrated biological adaptations, and they underlie all the clinical manifestations that we see when we give exogenous opioids, which are analgesia, hyperalgesia, tolerance, dependence, and addiction. In particular, these adaptations, hyperalgesia, tolerance, and dependence, don't just explain addiction, they also explain why opiates don't work terribly well when they're given continuously and for a long time. So we're not talking here about occasionally taking opiates. In fact, that must be distinguished because the whole field is beginning to recognize that effective opiate treatment tends to be the use of short-acting opiates taken intermittently, and that distinguishes us from what we've got used to is that all of these patients taking long-acting opiates, which are necessarily taken continuously. So there's always some drug in the system producing these adaptations. So I'm going to separate this introduction to Mark's talk about tapering into the issues of opiate-induced hyperalgesia, issues of tolerance, dependence, and withdrawal hyperalgesia, which is different, and I'll make that distinction. And the role of enduring adaptations, or what happens to make this whole thing, the tolerance and dependence, irreversible. So it doesn't just go away when you take the drug away, and that's why it all gets so difficult. So opiate-induced hyperalgesia, I'm not going to dwell on it because I talked about it quite a lot this morning and showed you all the molecular basis and genetic basis and showed you the changes, but this is a useful construct that when we first started talking about this, is in the anesthesia world anyway, what we were beginning to see is that we were treating people during surgery with very, very high doses of opiates, and we were seeing this adaptation that was changing the balance between analgesia, hyperalgesia, or pain and analgesia. And it wasn't until we withdrew the drug that you could really see the manifestations of this change in the balance. And eventually it would settle down to a new balance, but it would not go back to the original balance. It would be an exaggerated balance. So clinically you'd see recovery, but in terms of the systems and what was actually happening, it wouldn't be full recovery. So tolerance, dependence, and withdrawal hyperalgesia, I'd like to emphasize that they really cannot be separated. Tolerance and dependence are so closely linked. They sort of feed off each other. So it's not that you have this distinct problem of tolerance, meaning you need a higher dose to achieve the same effect, and that's distinct from dependence. It isn't, and I'll explain why. Tolerance has a very important psychological component. So it's not just a pharmacological process. There is a pharmacological component, and that is called non-associative or adaptive tolerance. And it's a cellular process. There's changes in receptors, receptor downregulation, and desensitization by things like the NMDA receptors and glutamate and all the things we talked about this morning. But importantly, there's also psychological or associative and learned tolerance. And that means that environmental clues, and that's an important factor in addicts who get to addiction through recreational use, and other psychological factors, which is important for anybody who becomes tolerant and dependent. And that is, you change the context, you change the circumstances, you change the mood, you change the climate, and the level of tolerance can change actually quite markedly. I just wanted to say something about the other aspect of tolerance is that clinically we can help with tolerance by switching opiates. So because there are so many different mu-opioid receptors, it's not a single entity, there are probably hundreds. There are certainly a lot that have been already identified. Because there's cross-tolerance between these receptors, we can restore efficacy or reduce tolerance if we rotate from one opiate to another. So for example, what we often used to do at the end of life when we'd lost the efficacy is rotate to methadone. But actually you can rotate from any one opiate to another, and that helps to reduce the tolerance. That's just an aside, but it's clinically important. And when I say dependence is inevitable with continuous use, as I emphasize, that means it has to be sort of, if it's round the clock and it's never out of the system, that is when you see these neuroadaptations. They come in three different sort of places that are important. One is physical. There's the effect on the noradrenergic system, particularly the structure, the locus coeruleus in the brain, that when the drug is withdrawn, that is what produces the distressing physical withdrawal symptoms, such as arousal, agitation, diarrhea. They're mediated by norepinephrine systems. And then there's emotional or psychological effects, so that you see a similar thing happening in the reward centers themselves, which result in anhedonia when the drug is withdrawn. And you see some effect in the pain pathways as you see this switch between analgesic effects and hyperalgesic effects. During withdrawal, withdrawal hyperalgesia becomes a very important bad symptom, particularly for pain patients, because they interpret that as they needed the opiate, without it their pain is going to get worse. So this is what we understand happens clinically with dependence, that initially you take drug because it gives you good effects. It either gives you euphoria if you're drug seeking or taking the drug illicitly, or in the case of pain patients, you get really good analgesia. But as these adaptations occur, you sort of, the balance changes. And so as we know, as well known in the addiction field, after a while, you're not taking the drug to give you euphoria, you're not getting a high out of it, you're just needing to take the drug in order to feel normal. And the same thing happens with pain patients. They need to take the drug in order to not have this hyperalgesia that occurs if they can't get the drug. So they're doing the same thing as people who take the drug illicitly. And it makes it very hard to take people off. So manifestations of withdrawal, these are the classic manifestations, but I just want to emphasize that for pain patients, the hyperalgesia that occurs is a really significant component in terms of the way they're processing what's happening to them. So this is just to say, to emphasize that you really can't separate tolerance dependence and withdrawal, because if there's a change, a psychologically induced change in tolerance, that's going to produce a withdrawal unless that increase in requirement is satisfied. So unless there's a higher doses given, then their symptoms are going to be bad. So there are all sorts of things that can happen in people's lives. In fact, it happens in people's lives anyway, even if they're not on opioids. But people who are on opioids have a different brain, and part of what happens to them is that their tolerance changes. They're liable to withdrawal, even if there's been no change at all in their dose. So the next thing that happens is that there are enduring adaptations. These are the things that arise, the neurobiological changes that actually aren't reversible. And that's why you often see relapse, even if you succeed in tapering someone, or you succeed in detoxifying somebody, you often see relapse because the changes have already occurred, and they explain why the brain is not the same, and it may take years for it to be a normal brain, if that happens at all. And they're the result of complex interactions between the drugs themselves and the circumstances in which they're taken. So they're going to be different when you have someone taking drugs illicitly from someone who's taking drugs for pain, because the circumstances are completely different. And remember that these adaptations may also alter analgesia and tolerance. So we've seen this sort of thing, that it's a second messenger effect, that there are epigenetic changes, there may be synaptic changes, there may be receptor changes, there may be actual pure morphological changes in the brain that don't recover. So what is addiction? And this is what we really struggle with in the pain world, because nobody who's taking opiates for pain wants to be labeled an addict. We don't want to use that label. We don't want to have to fragment their care so that they're no longer getting pain care. We need to refer them for addiction care. So, we really struggle with this thought process of what exactly are we seeing? Are they addicted, or is the dependence we're seeing something different? So this comes from an article I wrote with an addiction specialist, addiction scientist, in 2007. And it's based on a lot of the work that they've done with Mary Jean Creek in New York, that different factors produce this progression from the initiation of drug use to the final development of addiction and the likelihood of relapse. But the important thing is that initiation of use is more likely to occur with people with risk-taking personalities. So personality has a lot to do with initiation, with peer pressure, and with the type of drug itself. So we all know that a drug that has a very rapid onset is more likely to initiate addiction. It then progresses to intermittent or regular use, and finally to addiction and relapse. But the things that determine the second part of the progression from intermittent to regular use are things like stress responsivity, or coping strategies, or concomitant psychological disease, or psychiatric disease and social stresses. So this is what we see with pain patients. They don't enter at the initiation stage because they're prescribed opiates for the treatment of pain. They enter somewhere along the way, and they are very different people from the people who initiate drug use recreationally. So we think in terms of addiction. We develop our criteria. The DSM criteria are all based on behaviors that you see of street use. So we have this idea in our mind that this is what an addict looks like, but a pain patient who's struggling with dependence or addiction looks very different. The question is, are they biologically any different? What we see in pain clinics and primary care clinics, in fact, is no clarity, no bright line between the patient who's maybe addicted, or maybe we could say that by criteria they're addicted, and the patient who's clearly not addicted. So there are a few of the patients who are clearly not addicted, and there are a few of the patients that are clearly addicted. But so many of the patients we see are somewhere in this gray zone, and it's very hard to actually say that, do we know if they're addicted or not? Mark and I came up with this term, complex persistent dependence, to try and describe them without using the term addiction, because we think that they are biologically the same and they need the same sort of approach, even if you don't put the label addiction on them. So if dependence addiction develops through pain treatment on the left, characteristically, what you see is they're pestering reluctant doctors, and characteristically, the predominant symptom of their withdrawal is pain. On the right is the patient that develops addiction through recreational use. What you see in them characteristically is procurement behaviors. They need to procure opiates because they're not being prescribed it, and they become the predominant behaviors that get laid down in this memory of irreversible. That's why for them contextual cues such as drug paraphernalia are so powerful, whereas for the pain patient, contextual cues are more to do with pain itself. And the predominant symptom for them is anhedonia when they withdraw. In the middle, these criteria that we have come up with and decided are addiction behaviors could apply to either group, actually. But we tend to attribute them to the state of chronic pain or distressing lifelong pain is producing what is actually listed as addiction criteria. And I put craving in parenthesis because you don't see craving until you try and take people off. So I would submit you don't really know until you start trying to taper that in fact they have become so dependent it's really hard to get them off, and they have got this irreversible state. Another thing that makes it clinically hard with these patients is that pain patients don't accept that anything's wrong other than pain. It's very hard to persuade them that there is some dependence going on or even addiction. Whereas somebody who presents for addiction treatment for addiction is already accepted by definition that they're seeking help for an addiction problem. Pain patients find it very hard to do that. So what happens when you taper? You do see withdrawal symptoms that can be insidious and they can last for months. The withdrawal hyperalgesia can trick the mind into believing that opiates were needed. The difficulty of overcoming the withdrawal symptoms often hampers the efforts to taper opiates. The most difficult of all this to overcome is the psychological dependence. And the enduring adaptations may mean that you have a high risk of relapse even if you have a successful taper. And we know that from previous attempts at the UW, the University of Washington programs. Quite a lot of the patients that successfully tapered in the days when they were tapering from much lower doses than we're faced with now did relapse. So now I'm going to hand over to Mark to